We are here today. For those of you that don't know me, I'm Dr. Flo Weyerbach. I have been Ginger's chair for her project. So we are here for Ginger to present her project. Um, it's been delightful working with her. She is very committed to this topic and to the site. So her project is Promoting Aims for Tardive Dyskinesia, a program evaluation. So go ahead, Ginger.
All right, thank you.
If everyone else could mute, please.
All right. Thank you so much, Dr. Warbach. And thank you, Dr. Warbach and Dr. Lazier, for everything you've done to get me to where I am today. I couldn't have done this project without the two of you and Dr. Penland as well. You're one of my best friends, you know that. Anyway, good morning, everyone. And thank you all for joining me to listen to my defense on promoting aims to screen for tardive dyskinesia. And the first thing I want to do is just let you know what's coming. So over the next 15 to 20 minutes, I'll describe my project, but I'll start with a brief history and definition of what tardive dyskinesia is, and clearly try to state my problem that was before me and why I chose this project. I'll outline the groupings and literature that was on the subject of what I wanted to do at the clinic, identify the project's purpose, and introduce the framework supporting the methods used for analysis of the data. And then finally, I'll talk about the significance and clinical impact of the project in the clinic. So in 1951, a French surgeon was using chlorpromazine in surgery and recognized that it decreased psychosis in his patients. After much research, he realized this was consistent, and by 1952, it was approved to help mental illnesses. And sorry about the typo on the slide that I just noticed. It should say severe mental illnesses. By 1957, a German psychiatrist noticed that involuntary movements were present in patients taking chlorpromazine, and they didn't name the groupings of involuntary movements tardive dyskinesia until 1964. But there were a significant number of patients in drug clinical trials who were presenting with tardive dyskinesia, to the point that by 1976, the National Institute of Mental Health designed the Abnormal Involuntary Movement Scale. And from here forth, let's call it AIMS, because that's a lot of words for me to say. And this was to detect and rate tardive dyskinesia during clinical drug trials. By the 80s, newer antipsychotic medications were emerging. We refer to those as second generation or atypical antipsychotics. These medications had fewer cases of tardive dyskinesia, which was great, but it was still present. And it was just not as severe, which is also wonderful. But we still needed to treat it and decrease it. And it wasn't until 2017 that two medications were approved by the FDA to treat tardive dyskinesia. And the brand names of these medications are Austedo and Ingrezza. And it's a lot easier to say than deutetrabenazine and valbenazine. Anyway, so the two medications are wonderful, but the problem is still with us. We might wonder where the word tardive dyskinesia comes from, or the words. Tardive is a French word. It means late. And dyskinesia is a Greek word, which means abnormal involuntary movements. So makes a lot of sense. Frequently, tardive dyskinesia is not detected until many years after the patient has been taken antipsychotics. And so that's the reason the word late is attached. Tardive dyskinesia affects the face, torso, and extremities, and the movements can be mild, moderate, or severe. I deliberately made this slide busy because if you've ever seen someone with tardive dyskinesia, these movements are taking place without them being aware constantly. Either the eye blinking, rapid eye blinking, but more frequently, you see it in the mouth. The estimates from the literature show between 30 and 50% of all patients taking antipsychotics develop some degree of tardive dyskinesia. That's a pretty high rate. Thankfully, approximately 2/3 of those patients are never aware that they're having involuntary movements. And this basically means they have a mild or moderate case. And for many years, doctors wouldn't even try to treat tardive dyskinesia for mild or moderate cases, only if the patient asked. And relevant to this project, I want to remind us all that Healthy People 2020 set out a national goal for psychiatric professionals to improve how they manage medications by increasing product safety and decreasing adverse effects. And we need to be mindful that product safety means understanding risks and benefits, interactions like drug-drug interactions, appropriate uses, and also includes that we develop an astute awareness of side effects. So to promote safe practices, healthcare entities can adopt evidence-based clinical practice guidelines and impact how we serve our populations, improving efficacy, reducing side effects, reducing waste, and improve patient outcomes and quality of life. I know that's a lot, but it's our responsibility. So to state the problem, we've had a problem with tardive dyskinesia for definitely 60 years, going on 70 years. But in the earlier part of 2020, leaders of the site location for this project became aware that some of their prescriptions were being rejected by pharmacies. And it was being rejected because insurance companies require an accompanying AIM score to fill Austedo and Ingrezza. They also recognized that their procedure for managing antipsychotic medications had not been recently updated since the introduction of Austedo and Ingrezza, and that it was very difficult for them to find their manually uploaded AIMs because they were doing it on paper and uploading it into the electronic medical record, which I may call EMR at some point, I don't know. But anyway, so they made some changes. They updated their policy and they uploaded the AIMS form into the electronic medical record. And they decided they were going to use this version of the AIMS exclusively to assess annually for all their patients taking antipsychotics. And this project is simply an evaluation of the success of their implementations. And it's significant because it's important that we prescribe antipsychotics safely, that we evaluate the new programs and quality improvements initiatives that we start. It's important that we prevent, recognize, and treat the side effects caused by the medications we prescribe. And it's important that we know when to prescribe medications to treat tardive dyskinesia. And I do believe that the site location that allowed me to do this project was so committed to this task that it just did nothing but help me. And so I really thank Dr. Penland for that. I divided the literature for this project into 4 categories. There was the prevalence of tardive dyskinesia when comparing first and second generation antipsychotics, current clinical practice guidelines that had been updated since 2017 based on the evidence from research and especially based on the new medications, AIMS validity and reliability, and finally, because my original project was an education module, I looked into that. And so the majority of my literature had to do with education and policy development. And according to the literature, new antipsychotics definitely cause fewer and less severe cases of tardive dyskinesia. However, all of the researchers said that all antipsychotics cause tardive dyskinesia. So following the release of Austedo and Ingrezza, the American Academy of Neurology and the American Psychiatric Association updated their clinical practice guidelines. In these guidelines, it's recommended that all patients receiving antipsychotics have at least one formal AIMS screening a year, so no less than. And for people with higher risk, that they are assessed formally more frequently. Thirdly, research articles suggested that while AIMS had a Cronbach reliability score of 0.95, that there was a caveat to the rating. Accuracy was largely dependent on the experience of the clinician. So to address that and to decrease discrepancies in rating between clinicians, we can offer formal education and training for all clinical settings and for all professional titles. So it doesn't matter if they were a psychiatrist, a nurse, a therapist, they all did better when they received formal education on how to use AIMS. So the purpose of the project, again, it was really simple, really clear. We wanted to ascertain the impact from adding AIMS and updating the procedure. And we set out to do that by counting the number of AIMS that were completed. I'll say that the limitations that we had, that because it was really difficult to retrieve data prior to the implementation, we had nothing really to compare it with, but the evaluation is still valuable, especially to the clinic. And the theoretical framework. Number one, we all know that what a framework does is help guide a project. And so I chose the knowledge to action cycle, which is used frequently in quality improvement measures, but I only used the evaluation phase for this part of my journey, because originally, as you know, I started with a module for education, but ended up just doing an evaluation. And I say just, and I'm sorry for saying that word, but it was a portion of what I had intended to do. So in the knowledge to action framework, there's two main categories, knowledge creation and knowledge action. In the knowledge creation, we look at knowledge inquiry, knowledge synthesis, and the development of tools and products. Knowledge action is how we use the tools and products. With that, we identify problems, identify gaps between what we're actually doing in clinic and what the experts recommend. We recognize barriers to why people don't want to adapt, and then we help them to adapt. We encourage the use of clinical practice guidelines, and it also includes the evaluation and sustaining phases. And like I said, I use the evaluation phase to measure the success of adding AIMS to the EMR. And this was done through analysis, and it will show us whether the clinic needs to manage what we've done already, adjust it, or abandon it. And a lot of times with our quality improvement measures, we might choose to abandon it. Anyway, that's what I did. So based on the 129 form that I sent to the University Institute Review Board, the IRB determined that this was not human research or human subject research, and no further investigation was required. And that was a big hooray from me. After the site location updated the procedure for antipsychotic medication management and added AIMS to the EMR, the informatics technicians, who I'm not sure if they ever joined us or not, did me a huge favor, and they gave me a report. And what we did was we collected data between August 19th and November 26, 2020. And this was for all patient encounters involving all people who were seen at the clinic during those days, who were taking 5 of the most frequently prescribed antipsychotics. The data set that they gave me was on an Excel spreadsheet, and I transferred it to SPSS for analysis. This is my first finding, and I adjusted this one yesterday, which was, I felt so great that I woke up thinking about this. And I know that sounds weird, but I did. So of 2,167 encounters extracted, we saw 108 aims. And it looked like we only had 5% adherence. But then I realized when I woke up yesterday morning, wait, I didn't analyze the numbers of how many individual patients that was. And I wouldn't expect anyone to do more than one during a 2-month period. So there were 853 individual patients, which put us almost at 13% adherence to the new procedure, which is much more where we needed to be. Even if they continued at this rate, with only 3 providers using the electronic aims, they would be at 80% all annual aims completed for their patients taking antipsychotics, which was huge. And table 2 just looks at aims based on provider type. And at first this had a lot more meaning to me, but later as I thought it through, I realized that the 3 individuals, one was from each category. So 16 aims were from the one doctor, the one psychiatrist, 50 aims from Dr. Penland, and 42 from the one PA who was using the aims electronically. We do not know how many aims were completed on paper because none of that information was provided, but that would be something that the clinic could look at later. And this was just simply for my intrigue. I looked at the number of aims completed based on the medication, and then I put up some articles that basically showed me that this is almost exactly the rate in which these medications cause tardive dyskinesia. And that kind of blew my mind. I called Fran and I was like, Fran, you won't believe this. But literally, they're doing such an awesome job at the clinic. So one of the interesting details from that relationship, I've already said, but another one is that clozapine, which was once considered the best treatment for patients experiencing tardive dyskinesia, we understand now that clozapine also can cause tardive dyskinesia, and they too must be included in annual assessments. So they're not excluded anymore like we once thought they were. When compared in head-to-head studies with other antipsychotics, it does have the lowest rate of tardive dyskinesia, but it is still there. And in this table, we just see that the clinic, it is a really large clinic, and they do have several different locations. We looked to see if there was a correlation with who needed the education more, which locations needed the education more, and there was absolutely no statistic significance to this. It had a p-value of less than 5, but still probably valuable to the site location. And so this project is useful because it demonstrates the need for developing policies to support procedures. The procedures and the recommendations made by the American Association, Psychiatric Association is fabulous, but we need a policy that says exactly what we want done. It also shows the benefit of electronic medical records, accessibility within the record itself, so that we can produce reports like this. It indicates the need for ongoing education for employees to continue with developing tools as well as practicing and watching. One thing that I know from my own experience is what made me become really acutely aware when somebody has tardive dyskinesia is seeing it over and over. I mean, when you see it, You recognize it within a couple of minutes if it's in the face anyway. It also demonstrates the importance of evaluations to track progress of adherence to procedural changes. And my screen didn't move. There we go. So my plan for dissemination was poster presentation, manuscript submission, Wix page sharing, and an oral presentation. So the poster has already been presented. It was shown at the Sigma Theta Tau conference on April the 8th. I'm trying to prepare my manuscript to submit to the Journal of Nursing and Administration. Sorry, I stumble when I'm nervous, so forgive me. And the Wix page is my Wix page, and I plan to share it on my social media platforms. And an oral presentation, which is taking place at my former employer's office, and it's the Assertive Community Treatment Team. So that will be taking place later today. And then finally, to conclude, this project can impact how we manage medications and how we prevent, detect mental illnesses. It can be used to encourage clinicians to adopt research-based recommendations. It can be used to encourage them to develop policies that support their procedures. It can also be used to make screening tools more available for clinicians by including it in the electronic medical record, and to continue with developing training modules to accompany new policies and procedures. All of these are important aspects to how we manage care. And pretty much that sums up my project. I feel like I just rattled off a bunch of stuff, so I apologize. Anyway, I want to finally say thank you all so much for attending, and especially thank you, Dr. Lazier, Dr. Warbach. Thank you for everything that you've done. Thank you, Fran. Without you, there would have been no project, Fran. Thank you.
So, Ginger, thank you so much for that presentation. Can you stop sharing a minute so that we can have some conversation?
I would love to.
Great, thank you. So I really appreciated what you presented. I'm going to see if Dr. Lazier has any comments, and then if Dr. Penland does. I know that Dr. Penland was not on your committee, but I also know that she was instrumental in this project. You've answered all of my questions. I told you that yesterday, and then we'll open it up to the rest of the group to see if they have any questions. So Dr. Lazier, do you have any questions for Ginger?
Yes, first of all, I want to congratulate Dr. Bradley on doing a wonderful job. Okay. Yes. And I mean, you did a great job in this presentation. Certainly nothing to apologize for. You know this topic backwards and forwards. And this is an important project because to me, this is, you know, we have a lot of projects where people do certain themes. This was a really different one, and I think really important. The other I do have a question, just thinking about this. You and I were talking yesterday about you maybe working with, in a psych job with elderly people. What would the implications be for prescribing in tardive dyskinesia with the older adults? I was just curious about that, and you know, how does that work?
Okay, so I'm not sure I 100% understand the question. Let me try to rephrase it. So,
well, okay, in older adults, do you prescribe less of these drugs to try to prevent? I mean, is it lower dosing to prevent tardive dyskinesia, or you know, I'm just curious about that.
Yeah. Okay, right. So with the aging population, with any medication, there's going to be definitely concerns about their body's absorption and reactions. And yes, there's going to be dosing lower, titrating slower, using a lot more of those astute awarenesses of how they digest and absorb, and especially interactions with all the medications that they take. So there's a lot more caution when prescribing to the aging population.
Okay, just curious. Yeah, very good. Thank you.
How about, so some of you do not know, but Dr. Penland um, is a graduate from our program with a psych concentration. And Fran, I don't remember when you graduated. I just know that you were in my classes. But we are so appreciative of the work that you've done with Ginger and of the site. So do you have any questions for Ginger?
I graduated in 2016. It'll be 5 years in a few short weeks that I was graduating. I don't have any questions for Ginger, but the information she has actually provided to the agency has really been invaluable, because we are now, I was supposed to have a meeting after this with Jennifer Williams, but she had had some things come up, who's our quality management person, about what we needed to change from what we're doing in terms of staff education. And potentially some of the things that Ginger was working on initially when she was looking at providing staff education, we may actually request to borrow with credit to her, because my suggestion is going to be that we require more regular education modules than what we're doing. And potentially something that looks different than what we require on annual education when we do, our bloodborne pathogens and all that good stuff. Because the hope is that maybe if it's something different, it'll kind of stand out, and we can get some of our other prescribers more reminded of it and try to get them to switch over to technology. I work with some folks who have a hard time with some of the electronic forms in our medical record. And so I think we're probably getting some additional aims done, but you can't track them through a report if they're on paper.
Yeah.
Right. Well, Fran, I congratulate congratulate your office that I know that you had been doing it on paper, and you, I'm going to say, bit the bullet and put it all electronically, and that's how it's being monitored now. And I know that sometimes we do projects initially on paper, and then when we move it and they're successful and we move it to electronic, we don't necessarily evaluate it. So I think that Ginger, I commend you guys for putting it right into electronics when you identified the problem through the pharmacy. And I also congratulate you guys in looking at how you can continue to improve your processes, and looking at the systems that are in place and how the systems work together. I mean, that truly is the work of the doctorally prepared clinician, which you are, and which Ginger will be in a very short period of time. So I think that, I know that I have some other doctorally prepared clinicians on this call. I think it's very important that we look at, as doctorally prepared clinicians, what are the systems in place that impact the ability to deliver care to individuals, and how do all the systems work together to make that happen. So I really commend the site for all of the work that you did, and for instituting this when things didn't go quite according to plan. So that speaks to me the commitment that the site has and the strength of this project. Ginger and I talked yesterday, and she said, oh my gosh, we have all these encounters, but we don't have all these patients. And I said, yeah, we have duplicated and unduplicated visits. And she changed some things around yesterday. And I think that that's another important thing to look at is when were they being done? How were they being done? How are they being communicated to the pharmacy? I'm an old nurse. I know what it was like to see these individuals, and I'm glad that there's attention being paid to it. So I know that we have other people. I don't know if there's others that have comments. It looks like Dr. Hemphill wants to say something.
Good work, Ginger. I enjoyed learning things from your project. and I may have asked you this in the past, but I don't remember. Why is the recommendation for AIM screening only once a year, particularly since, you know, antipsychotics are pretty much chronic medication, or for chronic, to use for treatment of chronic conditions?
Yeah. And I meant to kind of say that, so thank you. So a formal AIM screening is recommended annually for those who don't have any symptoms, don't have high risks, and just, let's say you're taking Seroquel to sleep at night and you don't have mental illness. That's the kind of patient you want to screen for tardive dyskinesia annually, okay? This is the recommendation. You screen visually without a formal instrument every visit. Thank you for bringing that up.
Anyone else have any comments for, go ahead, Dr. Frazier.
I just want to congratulate Ginger. I just had the privilege to get to meet her and work with her this semester, but her passion for this project and her desire to improve the health of the patients who have tardive dyskinesia or who are taking these medications has been so evident to me, and I'm just proud of the work that she's done, and I just want to say congratulations.
Thank you so much.
I totally echo that, Dr. Frazier. Dr. Lazier.
Yes, I have a question. This is harkening me back to when I did my DNP project. It was called a capstone then. And I did something similar, that I evaluated a processes, and then I presented to the providers that were involved in the clinic. So here's my question. What recommendations do you have, Ginger, to the site for continuing to improve the rate of screening?
Yeah, so that's a very good question. And I've made some of my recommendations to Jennifer in an email because I knew she wasn't going to be here today. But definitely, I think that they need to, number one, have a policy supporting the new procedure. And the policy does need to state exactly what their expectations are. And it does need to address the annual for those without high risks, but more than annually with the formal aims based on the risks. So let's say you've got a patient who has IDD, schizophrenia, and they've had side effects. Let's just say they had contortions one time before they were prescribed Cogentin. Cogentin took care of the contortion, but they still have to take the antipsychotic, and they are at a higher risk for tardive dyskinesia because of those three things. Also, Cogentin increases the risk of tardive dyskinesia. So for that patient, I recommend no less than every 3 months of formal aims. And so understanding those algorithms would be important. I created an algorithm for the hospital. This project was originally going to be in a hospital setting. I had been approved by the entire hospital board that I had to go before. And then I decided to part ways with that job and go down to Charleston. Then they said they were going to let me do it at MUSC. Well, then I came back home to North Carolina. This project has traveled through several locations, okay? Which is kind of nice because I've brought awareness in 5 different areas, 5 different sites. So hopefully they've all decided to do something, hopefully. But thank goodness Fran and her agency, they're really doing this. They're not just saying, yeah, you could do your project here. They're really doing this, and it's been amazing. Yeah.
And Ginger, I think that you brought up a really important point, and that is we need to do projects that impact real people and real agencies. That yes, the project is the culmination of everything that you've learned and demonstration of what you've learned. But as nurses, we need to make sure that those projects impact the people that we care about. Because now the project is focused on a population of people, not on the individual. And as we focus on the population, we need to make sure that we're impacting the population. We're not doing a simulation on a population like we would do a simulation on a real live patient or on a patient. And I say that because I think that sometimes I'm concerned that we do projects that don't have real life meaning. I just think it's something that we all need to pay attention to, both as students, as expert clinicians, and as faculty, that we do projects, we supervise projects, and we do projects in our workplaces that impact the people that we care about and the people that trust us, because we are the #1 trusted profession. So great job. Do we have any other questions for Ginger?
Lee, I saw that you had hopped on. Lee, and I'm probably going to say his title wrong, is our Chief Operations Officer, I think is the correct title. And he's worked closely in helping to extrapolate the data that was given to Ginger for the project. Lee, did you have any questions, or did Jennifer pass on any questions to you she wanted you to ask?
She didn't pass any questions on to me, but if you have questions for her or information for her, just send that to me. And you can email me at lwalker@cvbh.org. Or you can email Frances too, and she can get it to me either way if you have her email readily available. But I'm here to support, and it's great to be on a call with so many wonderful people. I mean, you guys are just, I'm in awe of what you do for our clients, our patients. And I do agree with Florence that when it comes down to it, it's about the individuals. And I think I'm preaching to the choir when I say this, because of the people in healthcare, I think nurses understand more about the individual than anybody in the whole thing, because you have first contact in most cases and have most of the information. I've been in healthcare for 22 years, and it's always been the case that if we needed information, go to the nurse. Find your nurse, figure out what's going on, and work with them. And I just thank you all for what you're doing for our consumers.
Well, Lee, let me just say thank you, but do not discount the role that you play. Earlier this morning, I was on a interprofessional education call, and we were talking about the importance of the non-direct care professional within healthcare or within public health. I'm talking about the healthcare administrator. I'm talking about the epidemiologist. I'm talking about the information technologist. And while you may not be visible to the individual, the value that you bring for the clinicians to be able to do their job becomes so huge, because you're able to design systems for the clinician to capture the information, to validate the importance of what we do, and to continuously make improvements. So I think that this is, and this is why I said earlier, the systems that were involved in this project is just phenomenal. And we all need to learn how to work within our systems so that the individuals can benefit. So hats off. I've said this to Jennifer when I met with her, hats off to the organization for the good work that you guys do. I know that Frances is one of our study preceptors, and we love that about our graduates. And we love the organization for having our students there, not only to be precepted by Dr. Penland and the others, but also for projecting that makes a real difference. So thank you.